Oh, it's week 2. And nobody failed yet, so I guess I did something good. As you can notice, I put on my hat because it is also morning time, and your boy don't want to look homeless like he did week 1. Because we're going through a mental breakdown right now, and with homeless looking and mental breakdown, they can put me on 5150. We learned about that. 72 hours, bam! I don't got time for that. Okay, so we're putting on a hat to cover my homelessness hair. But before I begin, I want to do just kind of like a disclaimer to protect myself. I am in no way distributing my notes or any materials that I've taken in class, because I know that is considered illegal by your code policy. What I am simply doing is interpreting my own information that we have all learned in class as sort of an online virtual instruction, in a way where it's almost as if we were meeting together, but in this sense we're meeting online. So it's kind of like a form. That's what I want to go for. The comment section can be for questions so that we can all collaborate and answer each other's questions. And that's what I'm going for, okay? I am not, full disclaimer. If you fail, it ain't my fault, because you decide to click on this video, okay? And don't come for Andy. And definitely don't, tell me, because I'm gonna get kicked out and I don't got the time for that, okay? My camera's freaking out because it doesn't have the time for that. So without further ado, let's begin. So all of the resources are going to be the same resources that are available to everybody in Professor Dominguez's class. Just the key points and any practice problems I go over. So this is nothing like I'm sharing any ATI questions or nothing like that at all. These are the ones that are available to all of us. Another disclaimer to try to protect myself. Also, all of my notes that I make for this video are specifically for this video. So it's nothing that I did in class, etc. So without further ado, introduction to schizophrenia. So the things I'm going to be talking about in this section are essentially what is schizophrenia and the categories of the signs and symptoms. And then, elaborating on those categories, talking about like the alterations in thoughts or like behavior or perception. And then the phases of schizophrenia, which was a handout that we received. And the last one being just a brief overview of interventions, because we're going to be talking a lot about medications later on. So let's begin with what is schizophrenia, the first topic. So within this topic, let's talk about onset. Onset normally occurs within the late teens and early 20s, with its diagnosis being that someone needs to at least have one severe psychotic symptom lasting at least 6 months to get diagnosed with schizophrenia. And some general signs and symptoms, which we will talk about more specific ones, but just general signs and symptoms that you would normally observe in someone who has schizophrenia, is that they have extreme difficulty with self-care, interpersonal relationships, and the ability to work. And the reason why I say it's general, because we're going to talk about why, right? Because maybe they're disorganized thoughts, or they can't speak, or they're seeing stuff. So those are the specific ones. So basically, they have the inability to determine what is real and what is not. And so you might be asking, what is the etiology? What is the cause? There is no known cause. However, there is known risk factors, many being genetic and environmental. So an example would be twins. When you have a twin, it's like 50% increase that you would also get schizophrenia. Okay, so genetic does play a role as well. Epidemiology of schizophrenia, no difference related to race, culture, ethnicity, etc. Like I said, having an identical twin doubles the risk to 50%, and having a first-degree relative increases the risk up to 10%. So is there a cure? Unfortunately, there are no cures, which is why we're also going to be talking about medications down the line, because those just try to help dampen the signs and symptoms that they may have. It is chronic and reoccurring. However, if they're lucky, they could have just only a few episodes within their lifetime. So that concludes just an introduction of what is schizophrenia. Moving on to the next topic is categories of the characteristic dimensions of psychotic disorders. So I know that's really confusing, but these are like the general groupings, right? So because you can have disorganized thoughts and behaviors and positive symptoms, right? And then apathy and negative. And so we're just grouping them. So that you understand. So positive symptoms, as we've learned in class, are symptoms that are added, that were not normally there. So some examples are hallucinations, delusions, alterations in speech, bizarre behaviors, and we're going to talk about them specifically in the next topic. Negative symptoms are something that is being subtracted from someone that is normally there. For example, emotions would cause apathy. So all, if not most, of the negative symptoms are words that start with an A. Apathy, alogia, anergia, anhedonia, and avolition. So very easy. I'm pretty sure everyone knows this. But apathy, you can have a lack of emotion, blunt affect. Alogia, poverty of thought or speech. This is where when you ask them a question, they just can't find the words to say it. So they only say maybe a couple words. Anergia, lack of energy. Anhedonia, lack of pleasure or joy. You can, put them in their favorite place or on a roller coaster, and they're just gonna sit there stoic faced. And then avolition is lack of motivation in activities and hygiene. So loss of that almost goal orientation. That is a characteristic of a mentally healthy person. Then we have cognitive versus affective symptoms. Again, broad categories as well. These can overlap, okay? So cognitive symptoms are problems that deal with thinking, okay, that make it difficult for them to live independently. So for example, disorganized thinking, inability to make decisions, poor problem solving, difficulty memorizing things, difficulty concentrating on tasks, versus affective symptoms are manifestations that involve emotion. See how this overlaps? We know that negative symptoms is like apathy and etc. While affective can be like hopelessness, suicide, depression, anxiety. Those involve emotions as well. So these are just groupings of these specific signs and symptoms that we're going to talk about very soon. And so the thing to remember about affective symptoms, especially the ones dealing with anxiety and depression, hopelessness, we have to be concerned about the risk of suicide because those greatly diminish the quality of life for that individual. So patients are able to experience mentally healthy person characteristics with positive or negative symptoms as well. And that's something important to remember because it's not all the time that everyone's going to have everything in a mentally unhealthy person categories and symptoms, as we talked about in the last week. For example, loss of goal orientation and irrational thoughts, those kind of stuff. You may still have goal orientation, but you might have apathy, which is a part of negative symptoms. You see how that goes? So it's not strictly by the book. I'm going to have all the positive symptoms, all the negative symptoms, and no mentally healthy person symptoms. No, that's not how it works. It's a mix of everything, okay? Next is topic, the third one, is common alterations seen in schizophrenia. So this is a handout that we received. This is the very specifics that can fall into those categories I talked about. Either it's positive or negative or affective or cognitive. So let's go over them. I took these straight from the ATI book because there are a lot of terms that we need to know, but I don't think it's quite that difficult. So let's go over it. So let's continue and talk about those very specific signs and symptoms that we talked about. Everything I got was from the ATI book. I just typed it right now just to organize it so that you can see all the different terms that we have to remember. Now, everything in bold is everything that we talked about in class, everything that was emphasized in our PowerPoints or were maybe in the audio file that Professor Dominguez posted, or even in our key points. And the ones that are in brackets are the ones that we didn't go over in class, but you never know. ATI proctored, ATI quiz may have it, and Professor did say to go over all the terms anyways, so I just went ahead and made that distinction just so that we know, but I'm going to go over anything just to be safe. And they're everything, and they're very easy too. So let's start. The first category is alteration in thoughts, second, alterations in speech, third, alterations in perception, and lastly, alterations in behavior. And so alterations in thought, super simple. there's a lot, but I'm sure if you see it on the quiz or you see it as an example, I think you'll be able to identify a lot of these really easily if you understand like maybe the root words that are in the term. So for example, delusions of grandeur. Grand. Like you're so amazing. You're so grand. You're so fancy. You're so fancy. And so, not really, but like that's like you think you're God almost. Going into religion a little bit, but not really. But for example, I am the best basketball player ever. I am the best swimmer ever. I can take the test and get a 100% because I am so amazing, even though I am the dumbest person in the whole world. Anyways, delusions of grandeur. And then you have somatic delusions. See, somatic. Okay, and also a lot of the alterations are delusions, but besides the point. Somatic means body. So they think that their body is changing differently. So for example, they have like a third arm, or they think that they have a third leg. Okay, they don't see it. That's a hallucination. They just believe it. That's a delusion, right? Magical thinking, this is pretty easy. Magical, that they're able to control the environment or control others in some, magical way. So for example, I have a hair tie. I'm gonna put in my hair tie. I'm gonna be invisible. Nobody can see me because I'm invisible. I'm gonna put on my pee yellow shirt and I'm gonna be homeless, which I was week 1. Anyways, magical thinking. Thought withdrawal, again, thought withdrawal. It's like someone is taking your thoughts out of your brain, an outside source or an agency. Thought insertion, again, aliens or the government or whatever is putting these thoughts in my head. But more realistically, your patients would be like, stop putting that in my head. They think that you are telling them to do something in their head when really you're not doing anything. So thoughts being inserted. Jealousy, that's pretty easy. Dealt with that a couple times in my life. I'm just joking. Nobody wants me. Okay, ideas of reference. Okay, this one is I love because I just think it's funny. Okay, it's not funny to see in real life. Okay, but I just think it's me, kind of. So it's like these people think that like a small insignificant situation has significance. They attach personal significance to it. So you might be wondering, what does that mean? Misconstruing events. For example, someone maybe just be talking about tacos and burritos and what they had for lunch, and then the patient or me or anyone who has ideas of reference would be like, stop talking about me! You're talking about me! So that one is just, again, me. Everyone always talks so much smack. I'm always so bullied. What do I even do to deserve to be bullied? Anyways, depression. Persecution. Persecution is like they're being hunted after. FBI's after me. Being controlled, okay, obviously. A force outside is controlling me to do this. Thought broadcasting is like they think that everyone can hear what they are thinking. That's broadcasting. Their thought is being broadcasted. Religiosity, religion. Very obsessed religion. Alterations in speech. Word salad is obviously mix of words together, jumbled. Cup, tree, plant, flower, pee yellow shirt, homelessness, depression, anxiety. I don't know why I always do that. I just think it's funny. It's not funny. Okay. Clang association is very interesting. This is Dr. Seuss. They rhyme. I can't spit fire, so I can't do this. But flights of ideas, loose association, that's fun too. That one's like, oh, like I went to go pick up my son, and the sun is really hot, and the stove is hot. That's loose association. Echolalia is like they hear something and they keep repeating it. So repeating words, like a parrot. Neologism or neologism, or I don't know, is making new words, like smash more smooshity. Oh no, neologism. And then next category, alterations in perception. all five senses: auditory, tactile, visual, olfactory, gustatory. Pretty easy, right? The thing to understand is that in auditory, generally, they might have what's called command perception or whatever, because it's like a voice is telling them what to do. And then the last one, alterations of behavior, echopraxia. So echo is like kind of like repeat, right? Prax is like movement. So that's why they keep doing the same thing over and over and over and over, imitating movements that are like made. So they might see like someone do something, and they'll repeat it. Or they might see like a race car driver, and they're going like that too. They're just repeating, imitating, just miming. Stereotype behaviors is similar but not the same. Stereotype behaviors is like something in the past that was insignificant. They are mimicking now. So for example, past motions, I mean. So generally they're with professions. So like, vacuum cleaner, they vacuum, right? Or they are laying down bricks, or they're doing this. That's stereotype behavior. So you'll see them just vacuuming, pushing the hand. Nothing's there. Okay? They look a little nasty. And then waxy flexibility, it's like they're encased in wax. So just be walking and then just... Yeah, we're wasting time. Maintaining specific position for long periods of time. And then extreme agitation, obviously, we understand that. Stupor is like being in a coma-like state. Okay, that's why a patient that's stuporous, he's just out, but they can respond to pain. Coma-like state, motionless. Automatic obedience is responding in like a robotic way. So if anybody did the ATI, real life ATI for mood disorders, which I know is not the same thing that we're talking about right now, but one of the patients, when she responded back to the nurse, she was like, "Okay, Ben, I'll go do that." That's automatic obedience. It's like being robotic. And then negativism is doing opposite of what is asked. That's pretty easy, right? So as long as you understand the root of everything, I'm sure you're able to understand what that question is pertaining to. So our next topic that we're going to be talking about, our fourth topic, is the phases of schizophrenia. So this was a handout that we received in class, and so I just kind of combined that with the PowerPoint, and just to make things a little bit easier for ourselves. So here we talk about the prodromal phase, the acute phase, the working phase, and like the maintenance phase. So pretty similar to what we've learned prior, but now we're using it for schizophrenia. So in the prodromal phase of schizophrenia, what is it? Well, anything prodromal means that it's the onset of symptoms as a forewarning. So these aren't the full-blown acute symptoms that we would see in phase 1, which is the acute phase of schizophrenia, because they are symptoms that are prior experience before the first psychotic episode. So how long does this normally last? Normally between 1 month to 1 year. And some typical signs and symptoms that a person in the prodromal phase may experience may be social awkwardness, loneliness, depression, new anxieties, phobias, obsessions, and then subtle changes in their personality. Okay? And that leads us to stage 1, the actual stage of schizophrenia. This is called the acute phase. And so the acute phase is the exacerbation or onset of symptoms. This is when they actually begin to experience those signs and symptoms that we talked about prior. The positive or affective symptoms, or the cognitive or affective. I put positive and affective. Positive and negative, then cognitive and affective categorization of symptoms. So they can be experiencing any of those. And so think about it. What is our importance? What is our focus for treatment, especially if they're in the acute phase of it or exacerbation? Well, think about it. Perception issues, hallucination issues. They may be thinking or seeing things or hearing things that aren't there. And what if they are a harm to themselves or harm to others, right? So our focus for treatment, especially if they're in the acute phase of schizophrenia, is definitely safety. So an example would be facilitation through a 5150, as we learned in week 1, because we need to make sure that they're safe and everyone else around them are safe as well. So after the acute phase would be a phase 2 of schizophrenia, which is considered the stabilization or working phase. So this is where symptoms begin to diminish. And this is where I combined a lot of things from the handouts that we talked about, just so that, we cover everything. Talking about patient experience versus focus of treatment. So here the patient will experience, as I said prior, a decrease in symptoms, right? So a decrease in acute positive symptoms or a decrease in acute negative symptoms. So for example, how would you know if a patient is improving in anergia, right? That's a negative symptom. While maybe they're beginning to participate in things a little bit more, right? Alogia, maybe they're beginning to say sentences now, which is definitely an improvement. So just be sure to understand, situations so that you're able to document improvements, right? And so again, focus of treatment here, stabilization, bringing back to baseline is a big one. And so what do we employ here to do that? Sometimes we may be employing therapy or medication, which we will talk about later on. And then lastly, phase 3 is maintenance phase. This one is where they're already at or near baseline functioning. So all we have to do is just prevent relapse. Patient education is very crucial here, okay? So the problem is, as is the same week 1, medication adherence has always been a big thing. They're going to have to take these medications, pretty much lifelong because it's a chronic reoccurring issue. So if there is a reoccurrence that is occurring, then we definitely need to refer them to the ACT. Remember, the Assertive Community Treatment Program, okay? And then the last topic of this entire introduction to schizophrenia are the interventions that may be involved. So again, we're going to be talking about, I know I keep saying that we're going to be talking about it later on, but this is just the introduction phase. So when we talk about neurotransmitters and how the brain works, which is in this video, relax, then we will fully understand in depth. The reason why I do this is just so that you have a roadmap and so that by the time we get there, you recall some of the things that I've already prior talked about. So interventions, antipsychotic medications are a big player in trying to stabilize their mentation. So we have first generation and second generation, and then we also have our anticholinergics, which will help balance our EPSs, okay? And then lastly, we also have therapy as well. So that's just kind of like a brief overview. So let's talk about first generation medications. Just getting our toes a little bit moist, okay? So these are great to treat positive symptoms of schizophrenia. So things that are added, either hallucinations or delusions or, all that kind of stuff. So our medications is haloperidol, loxapine, chlorpromazine, and flufenazine, okay? I know it sounds all alike. I also have some general considerations that I got from the ATI book, and these are very basic. Understand that all your medication facts are in that handout that we received in class. So the reason why I say that is because the general considerations for these medications is to minimize anticholinergic effects. So water, 2 to 3 liters a day, high fiber, and also monitor for orthostatic hypotension. So our nursing interventions for that would be like slow postural movements, okay? And that's because these have anticholinergic effects and also orthostatic hypotension effects, which is in our handout. Our second generation medications, these are great to use if they're experiencing positive or negative disorders, okay? So we can use it for both. But generally the negative ones, because these are the only ones that help with that, right? So our medications, and I kind of have a little mnemonic. It's rock. Rock with a Q. Like, those fancy. We're saying it fancy, okay? Rock. So ROCQ. Risperidone, olanzapine, clozapine, and quetiapine, okay? General considerations for this is weight gain, okay? Minimizing weight gain. They might have some sedation, agitation, dizziness, and maybe some sleep problems, sleep disruption. And then one very important thing to remember is agranulocytosis associated with clozapine, okay? And then our last topic or introduction to the medications are our anticholinergics. So you might be wondering, why might we give anticholinergics? Well, the first generation meds have a very, very high incidence of also extrapyramidal symptoms, okay? So we didn't go over that because that's a very specific consideration. I only talked about the general ones, but we would prescribe benztropine and diphenhydramine to try to minimize the EPS effects. So generally they might prescribe it together to do that. And obviously our adverse effects would be heightened anticholinergic effects, so dry mouth, urinary retention, constipation, mydriasis, etc. So that's medication for interventions that we may employ, but we also have therapy, remember? Psychoeducation, symptom management, listening to music, therapeutic communication, and a very key important note that I will talk about later on as well near the end, because we're talking about therapeutic communication in specific. Again, this is just the introduction section. Make sure that you are acknowledging and also displacing their belief. Very important concept. So for example, if they're like, I see a clown, you don't see a clown there? It's very important to be like, I'm using the same example that we did in class, okay? So don't clock me, but just saying like, it does seem very concerning. You seem very concerned. That seems scary that you're seeing a clown. However, that's highly unlikely because we're in a hospital and there are no clowns in a hospital. It's like displacing belief, but also acknowledging their fear. So it's therapeutic. Okay. With that being said, that concludes interventions for our introduction. Okay, so let's review our first section, Introduction to Schizophrenia, and just talk about some of the review questions. So, what is schizophrenia? Remember, onset of it is late teens, early 20s. Diagnosis, at least one severe psychotic episode. What are some general signs and symptoms that you would associate when you just see someone with schizophrenia? Maybe they have self-care deficits, interpersonal relationship problems, and then the lack of the ability to work. And this is when they have the inability to determine what is real and what is not. Is there a cause? There is no known cause, but there are many known risk factors involved, many including genetic and environmental risk factors. Any differences between race and how they receive it, epidemiologic, no link between races or social economic status either, or even culture. But there is a genetic link, okay, between twins and also 50%, and also first degree relative up to 10%. Is there a cure? No cure. It's chronic and reoccurring, but they may only have a few episodes in their lifetime. So second topic that we talked about introduction is categories of the schizophrenic signs and symptoms. Okay, so we have positive versus negative symptoms, and then cognitive versus affective symptoms. So positive symptoms are things that are added. Okay, hallucinations, delusions, alterations of speech, bizarre behaviors. Negative symptoms are things that are subtracted. Okay, so all the A's: apathy, alogia, anergia, anhedonia, avolition. Okay, remembering the differences between those as well, which are pretty easy. Alogia, lack of words; anergia, lack of energy; apathy, lack of emotions; anhedonia, lack of pleasure; avolition, lack of the goal orientation, lack of motivation. Cognitive symptoms. We talked cognitive symptoms versus affective symptoms. Cognitive, we talked about problems with thinking, so disorganized thinking, inability to make decisions, maybe memory. Affective symptoms are manifestations involving emotions, so hopelessness, suicide, depression, anxiety, and remembering that individuals who experience affective symptoms are at risk for suicide. So be very careful for their safety. And a takeaway note of all this combined is that an individual does not have to have all these signs and symptoms or all these categories that we are talking about. Remember, they can also exhibit mentally healthy characterizations as well. Someone can be goal-oriented. Someone can be, have rational mind, but have loss of energy, right? Have avolition. So it's very important to know that. Now, the third topic is the very specific categories that we talked about, all the specific signs and symptoms that are grouped. So we have alterations in thought, alterations in speech, alterations in perception, alterations in behavior. And, just going over very quickly, because there is a lot, delusions of grandeur, that's you're all powerful and important. Okay, you're the best in everything you do. Somatic delusions, body delusions. Okay, thinking your body is changing in an unusual way. Third eye, third arm, second nose. Magical thinking, actions or thoughts are able to control situation. Thought withdrawal, thoughts are being removed from an outside agency. Thought insertion, thoughts are being inserted from an outside agency. Jealousy is jealousy and it ain't cute. Ideas of reference, misconstruing events and attaching personal significance. They're talking about me, even though it might just be a TV. Persecution, feeling singled out, okay, being hunted down. Being controlled, another force outside, they're controlling their body to do something. That's different from thought insertion, okay? This is like, they're making me move my arms, They're controlling their body. Thought broadcasting is their thoughts being broadcasted and they're thinking that other people hear what's in their head. Religiosity, obsessed religion. Word salad, jumbled words. Clang associating, the rhyming of words. Ideas of flight of ideas / loose association. Sentence after sentence that don't relate in the same context. Echolalia, repetition of words. Neologism is making of new words. And then, alteration perception, we talked about all the 5 sentences: auditory, tactile, visual, olfactory, gustatory. But remember, auditory, they might have command perception, which is where that voice is telling them to do something, commanding them. Alterations in behavior, we have echopraxia, imitating movements by others. Stereotype behaviors, motor patterns that used to have meaning, but are now mechanical and lack purpose. Like, for example, the guy that was a bricklayer, he's laying bricks now and he's not doing anything. A maid or pushing a vacuum cleaner, just going through those simple motions again. Waxy flexibility is maintaining specific position for long periods of time. Extreme agitation is obviously agitation. You'd see them pacing or rocking or fidgeting, right? Stupor is like stuporous, right? So motionless, coma-like. Automatic obedience, automatic robot. Negativism is doing the exact opposite you tell them to do. The 4th topic we talked about is the phases of schizophrenia. We talked about the prodromal phase, phase 1, which is the acute phase, phase 2, which is the stabilization / working phase, and phase 3, which is the maintenance phase. So in the prodromal phase is the onset of symptoms before the exacerbation or before the actual signs and symptoms occur. So it's a forewarning. Duration is normally 1 month to 1 year. Signs and symptoms that you would normally experience, again, they're kind of more minor. Social awkwardness or maybe loneliness, depression, newer anxieties or phobias, obsessions, and then subtle changes in their personality. Then you have phase 1, which is the actual acute phase of schizophrenia. This is where they actually start developing the onset of the specific signs and symptoms, the exacerbation of those symptoms. So everything we talked about before, the positive, the negative, the affective, the cognitive, and all those categories, okay? And our treatment priority here especially is to provide safety. The second phase is stabilization / working. This is where it's diminishing. So patient will experience diminish in the acute phase signs and symptoms. And so understanding how to put this into context and how to document is very important too, okay? Because how do you know they are improving, okay? So anergia improvement, apathy improvement, alogia improvement, what would that look like? And then focus of treatment, stabilization, and bringing back to baseline. And this is where we can use medications and therapy. Then maintenance is they're already at or baseline functioning. And our goal is to prevent relapse. And how do we do that? Again, it's connecting them with the resources, community resources, and a big problem, again, is medication non-adherence. So we definitely, if they're having reoccurrence, they're getting hospitalized over and over again, ACT is a very big program that we need to get them in. And lastly, we have our interventions. We talked about antipsychotic medications. We have first generation, second generation, and then our anticholinergics. So our first generation, remember, this is our haloperidol, loxapine, chlorpromazine, and flufenazine. And our general considerations for this is just, managing the anticholinergic effects. So 2 to 3 liters of water, an orthostatic hypotension, high fiber diet, etc. General, okay, we'll go into the specifics later on. Second generation, these are the ones that, first generation is great for positive signs and symptoms. Second generation is for positive and negative signs and symptoms. This is ROC, so risperidone, olanzapine, clozapine, and quetiapine. So a lot of the penes. Except for the first one. Okay, the first one loxapine, so don't get mixed up. Okay, don't listen to me. General consideration for this one is weight gain. Okay, agitation, dizziness, sedation, and maybe sleep problems. Now, the problem with this one specifically is clozapine is agranulocytosis. Anticholinergics, we take this to help minimize EPS effects, which are very common in first generation antipsychotics. So this is going to be your benztropine and diphenhydramine. Adverse effects obviously are anticholinergic effects, myiasis, dry mouth, constipation, urinary retention, etc. And then lastly, for our therapy, for interventions, again, psychoeducation, listening to music, our non-pharm stuff. And if they're experiencing psychosis, we have to acknowledge what's going on and displace that belief. So let's go over some practice questions now. A patient with schizophrenia says there are worms eating at my skin follicles. What would you classify this assessment finding? Obviously, is this a positive symptom, a negative symptom, a cognitive symptom? It's a positive symptom because it's things that were not there prior. Which statement by a nursing student indicates an understanding of the etiology of schizophrenia? So schizophrenia disorder in the brain that is cured with correct treatment. A person inherits schizophrenia from a parent. Problems in the structure of the brain cause schizophrenia, and schizophrenia is caused by various different factors. And it's D, the last one. Remember, we don't have a specific gene or a specific thing that causes it. It's just a cluster of things. Remember, diathesis stress model, sometimes it just activates. Which assessment finding represents a negative symptom of schizophrenia? This one's pretty easy. Delusion, motor tics, hallucination. It is obviously apathy, which wasn't those 3. And with that being said, let's move on to our next topic, or our next chapter. Okay, so let's start our next chapter. So that was all introduction before to schizophrenia. Now let's talk about biological basis for understanding psychiatric disorders and treatments. So a lot of anatomy and physiology. Finally here we get to talk about, our drugs, and then focus on the extreme complications like EPS, NMS, NMS, and agranulocytosis. So a little bit of a roadmap in this chapter. We're going to talk about just anatomy and physiology review, such as like the neurotransmitters and the parts of a neuron. And then we're going to talk about our psychiatric drugs, very specific now, in depth now, okay? So we talk about our first generation antipsychotics, which are our conventional antipsychotics. Then we have our second generation antipsychotics, which are atypical ones. And then we're going to focus on those specific adverse effects, NMS, EPS, agranulocytosis, what the components are for that, what those entails, what our nursing interventions could be. And yeah, so without further ado, I think that's only 3 topics. No, there's not. We'll go as we go, okay? So let's start with anatomy and physiology review, okay? So cellular composition of the brain. So here we talk about parts of the neuron. So neuron, what's the function of a neuron? Easy peasy, communication using chemicals to each other. And that's how we get our information. We move, we do all kind of stuff, okay? Impulses travel in one direction, from the dendrites to the cell body, to the axon hillock, to the axon terminal, and then to the synaptic cleft, right? So those are the parts of the neuron. Now, some specific things to think about is, remember, the axon has the myelin sheath, which allows for rapid conduction of electrical impulses. Remember, the axon terminals are what hold the neurotransmitters and they get released into the synaptic cleft. So that is a presynaptic neuron. And then when it gets released into the synaptic cleft, hits the receptor on the postsynaptic neuron on the dendrites. That's how neurotransmission is started. So again, I already answered myself. Neurotransmission or neurotransmitters, they travel through vesicles within the neuron, released into the synapse. And what happens then afterwards? Well, when the neurotransmitter is not needed anymore, it's called neurotransmitter destruction. So either we use an enzyme and we break it down, or we re-uptake it and we remove it from the synapse. So that's a basic cellular walk through anatomy physiology. So now this one's more important. Our neurotransmitters specifically, which is a good segue point. Here we talked about serotonin, norepinephrine, GABA, and dopamine. And so we did a little activity during class where we went outside and, we had different color cups with different colors representing different neurotransmitters. And so low serotonin means depression. Low norepinephrine means low energy. Low GABA means anxiety. But then individuals who had schizophrenia, dopamine is high. Remember, it was just pouring everywhere. High means hallucination. So those are very important to remember and to correlate, okay, when we look at our patients. So that's the first section, anatomy physiology review. Let's now talk about our antipsychotic drugs. Finally, in medication. So first generation antipsychotics, conventional. So this class is dopamine antagonists. They block dopamine receptors. Now, these are greatly indicated for positive symptoms of schizophrenia. Our medications, again, are chlorpromazine, haloperidol, loxapine, and flufenazine. Remember, these have the highest risk of EPS, and these are actually very cheap. Our second generation antipsychotics, or atypical antipsychotics, the class is dopamine serotonin antagonists, so they block both. And these are indicated for positive and negative symptoms. So an example of when you would give this is, I have no energy, I have no motivation to do anything, and I may see shadows. See, that's positive and negative. It's perfect to use this then. Our medication is ROC, remember? So risperidone, olanzapine, quetiapine, and clozapine. Okay. The cool thing about this one is that they have a very low incidence of extrapyramidal symptoms, but we can still get them, as well as it being extremely expensive. So now with that little brief overview, let's do side effects. Let's learn them now, right? So let me just minimize my ugly self. Okay, so how I have it laid out here, and I have little mnemonics, are antipsychotics first generation. See, I have them right here. Side effects, okay? Very important to remember the special ones, okay? What do I mean by the special ones? Well, the mnemonics that I have planned do not account for these big ones. The reason why is because I want them to stand out to you, because they're pretty significant, okay? So I didn't want to mix them in, but we'll talk about later on because there's a lot of similarities between the two. So as long as you understand the similarities and the differences, this will help greatly, as you will soon find out. So the special ones to remember for our first generation antipsychotics is EPS and NMS. The reason why NMS is because this is when dopamine is too low. So you might be wondering, why would dopamine be too low? Remember, both of these antipsychotics, they block dopamine receptors. And so even though we only want them to block in the brain when we're having the most problems, they block everywhere throughout the body. And so we're going to have a lot of severe signs and symptoms, which is why which is why NMS shows up in also the second generation as well. And we already know that EPS shows up in both. The only difference is EPS is higher in one and lower in the other. So that's why I want to bring that up. So now let's talk about the other side effects that are part of our handout that we were given. Again, I'm just kind of going off of this just because it's he said we can learn it by class. However, we don't know. So I highly suggest reading chapter 24 in our ATI book so that you can really get a good understanding of it. I can't go through every single page, which is why I'm doing it this way, and hopefully it helps you when you do read the ATI book, okay? So, our side effects is AWOL times 4. So the reason why I did AWOL is because a lot of the signs that I've seen in the clinical side, it says high risk of AWOL, which is why I could remember antipsychotic the first generation. So I did AWOL times 4 because, I think it's a level. It's like, a level 1 is like lowest risk, and then level 4 is like highest risk. So AWOL times 4, highest risk, right? And you might be wondering, why 4? Because it's 4 S's. I could have done AWOL times 4s, like S, which I could do that. But, I'll do that. So it's just so you guys know. AWOL times 4s. So it's a lot. High risk. Anticholinergic effects, weight gain, orthostatic hypotension, liver impairment. And then the 4 S's, sedation, seizures, sexual dysfunction, skin effects. Hopefully that helps a little bit. Having something to go off of does make it easier to remember things. So AWOL times 4. One more time. AWOL times 4s. So anticholinergic effects, A. Weight gain, W. Orthostatic hypotension. Liver impairment. Sedation, seizures, sex, skin. So remember our nursing interventions for these, okay? Do not forget them. Anticholinergic effects, as I said prior, okay? Making sure that we're taking 2 to 3 liters of fluids. We're, exercising. We're eating high fiber diets as well, okay? Weight gain, managing that. Orthostatic hypotension, we want to make sure that we are doing slow postural changes, dangling the feet, besides the bed before we stand up. Liver impairment, okay, then we have to monitor what? AST and ALT. Don't forget those, okay? I think S before T, so 0 to 35 and 4 to 36, but you can correct me if I'm wrong in the comment section, okay? Now I'm looking out for those because you definitely do not want to give it if they have very high levels of it, all right? Or some side of liver disease. You don't want to give this. Sedation, obviously, seizures, sexual dysfunction, skin effects, things of that nature. So that's that. Our second generation, remember ROC, risperidone, clozapine, olanzapine, and quetiapine. Our side effects is, ass. So I kind of paired it together because these are all our antipsychotics. So what happens if they run away? Ass. Like you're pissed. And remembering the special ones again, see? EPS, fewer, NMS, with the exception of agranulocytosis. So you might be wondering, wow, these look so similar, right? I put them that way so that you understand that the first 3 are literally in the same group before. So O, orthostatic hypotension, C. Anticholinergic effects, C. Sexual dysfunction, C. The only one that's different, aside from agranulocytosis, was the exception, which is the special ones. I didn't want to put that in the mnemonic. Sleep disturbances. Okay? So, obviously, you want to promote restful sleep. So, I'm just kind of going off the cuff. I don't know if it's 100% it, but obviously doing our sleeping interventions. So, do we want to exercise before we go to bed? No. No exercise 2 hours before bed. We don't want to eat before bed either. We don't want to drink caffeine or anything like that as well. Okay? So, what are the same, again, as a repeat? Orthostatic hypotension, anticholinergic effects, and sexual dysfunction. So let me make sure that I got everything. Yeah, so as far as the agranulocytosis goes, the EPS and the NMS, we are going to be talking about that in our next topic. So this is just a brief kind of overview, actually specific overview, I should say, of all the side effects. So now we're going to be talking specifically of those special considerations, the extrapyramidal symptoms, NMS, agranulocytosis, etc. So hopefully this grouping helps you to study and to just understand it. So now let's focus specifically on those extreme complications that I singled out before. EPS, NMS, agranulocytosis. And I'm also going to add another one, which I did not mention, but anticholinergic symptoms / toxicity. And the reason why I'm incorporating that in as part of our extreme complications is because, think about it, all of them, including benztropine and diphenhydramine, the two drugs that we administer to try to reduce the EPS occurrence, they're all anticholinergics. Remember that first generation has anticholinergic effect, the second generation has anticholinergic effect, so that's why we have a anticholinergic toxicity as well, okay? So that's where that's coming from. But we are elaborating off of those ones that I singled out from the topic prior. So without further ado, let's just get started. So starting with extrapyramidal symptoms, right? Acute dystonia, pseudo-Parkinsonism, akathisia, and tardive dyskinesia. So those four are the characteristic findings of extrapyramidal symptoms. So acute dystonia is sustained, often painful muscle spasms that produce abnormal postures. So the muscle cannot release. It's like, and you can see the tone in their muscles, okay? So it's like they're stuck. They're just stuck in some sort of awkward position like this. I can't believe I did that. So bad. So disgusting. I am just terrible. Anyways, next one is pseudo-Parkinsonism. So this one, very, very similar to the signs and symptoms of Parkinson's that we learned prior. So shuffling gait, hunched posture, slow movements, okay, pill rolling, slight tremors. So why do I say very similar? Okay, because remember, in med-surg or pharmacology, shuffling gait, slow movements, and tremors were the signs and symptoms of Parkinson's. So the only exception to that, which we have a couple additional ones, is that hunched posture and that pill rolling in the hand, okay? So that's pseudo-Parkinsonism. Then the next one is akathisia. Akathisia is constant state of agitation, distress, and unrestfulness, okay? And just a little, fun fact that I read in the book, fluphenazine especially causes this, but we don't need to know that. That's just because that's what the provider does. So just a little thing. The last one is tardive dyskinesia, okay? So tardive dyskinesia, abnormal movement of the face, jaw, and sometimes even arm, okay? So what are they? Lip smacking, arm flying out, stretching neck out, tongue thrusting, okay? So they're just gonna have random abnormal movements like whoa, 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 yeah, come on. I need friends. And then lip smacking, and then stretching neck out. What that neck do though? And tongue thrusting? What that tongue do though? Oh, oh crap! I shouldn't have said that. Oh, don't demonetize me now. Why so much municipality? Anyways, tardive dyskinesia, lifelong, non-irreversible, okay? Okay, that's extrapyramidal symptoms. Now we have anticholinergic symptoms / toxicity, the one that I wanted to talk about. It's just how I organized it. I'm sorry, maybe I should have NNS, but it's very fast. So essentially everything you associate with anticholinergics, you have your dry mucous membrane, you still have your urinary retention, you still have like the mydriasis, so non-reactive pupils, pupil dilation. So what are you going to expect? Photophobia, blurred vision, absent and reduced peristalsis as well. Okay, and tachycardia. So those are kind of like my, not as severe signs and symptoms, but then the more severe ones is delirium, seizures, and repetitive motor movements. Okay, so I kind of separate it like that. Next is NMS, neuroleptic malignant syndrome. Remember, this was common in both of them. Why? Because both block dopamine. So what happens? The cause? Too little dopamine, taking too much antipsychotics, causing excess blocking of dopamine. This is because dopamine is blocked throughout the entire body, even though we only want it in the head. So very important to remember this. What are our signs and symptoms? Hyperpyrexia, muscle rigidity, okay? Then we have BP fluctuations, tachycardia, tachypnea, and then decreased level of consciousness. So I learned by grouping things, and that's how I grouped it. So do you remember malignant hyperthermia? Very similar, right? High fever, muscle rigidity, and heart rate increase, a breathing increase, BP, weird, right? As far as I remember, that's just what I'm saying. So I grouped it like as that. So the first, hyperpyrexia, muscle rigidity, right? Because that's what we know from malignant hyperthermia. Then we have tachy, which is tachypnea and tachycardia. And the BP is just all over the place, flexing up and down. Very important to know that, as we'll talk about later on. And the decreased level of consciousness. Okay, so you'll see like drooling or something. And the reason why the BP fluctuates is because baroreceptors are unable to, send messages of how the blood pressure should be. So it's unable to communicate. So one moment will be really high, one will be really low. Okay. Nursing interventions. Okay. So for the muscle spasms and the muscle rigidity, okay, just like before, we administer dantrolene. Okay. High temperature, just like before, we can do acetaminophen. But blood pressure, we cannot do anything, okay? Because it fluxes too much. We can't do a beta blocker because what if it's low? Then it'll tank them more, all right? And then the next one, the last one of our special considerations or special adverse effects is agranulocytosis. And the reason why is because this is self-destruction of white blood cells, specifically with clozapine. So our nursing interventions is to do monthly lab levels of white blood cells. So we need to educate them that they're going to be coming back frequently to get their blood checked, especially for the white blood cells. So what would make you check the labs if they were on clozapine? Well, sometimes they may be exhibiting flu-like symptoms, which is bad because white blood cells is low, right? So we're looking for like a runny nose, a sore throat, etc. All right, so a little bit of a review. If a person has decreased circulating levels of GABA, which health problems would be expected? Alzheimer's, Parkinson's, anxiety, or insomnia? Anxiety, as we talked about already. And with that being said, let's move on to the biological review for this concept. So let's review biological basis for understanding psychiatric disorders and treatments. So here we talked about just anatomy and physiology review. So cellular composition of the brain, we talked about what a neuron is, what its function is, communication of signals by sending chemicals, what the parts of the neuron is, so dendrite, cell body, axon, myelin sheath, axon terminal, synaptic cleft, etc. And then that leads to neurotransmission. Neurotransmitters are traveled through vesicles within a neuron and released at the synaptic cleft, where they are taken up by the neurotransmitter receptors on the postsynaptic side. And what happens then? Well, we don't want to stay there forever, so neurotransmitter destruction. So either we reuptake or we enzymatically degrade it. Okay, and so now segueing to neurotransmitters, what are our specific neurotransmitters that were involved that are imbalances may correlate to certain disorders, right? So serotonin low is depression. Norepinephrine low is low energy. GABA low is anxiety. Dopamine high, that's where we get our hallucinations from. Then we finally talked about our psychiatric drugs. So our first generation antipsychotics, or our conventional drugs, the class, remember, is dopamine antagonist. So it blocks dopamine receptors everywhere. Indication for positive symptoms. Remember, positive things that are added. Medications, we have chlorpromazine, haloperidol, loxapine, and flufenazine. Remember, just singling out the specific adverse effects. Remember, the severe ones for this one were EPS, also NMS. EPS, very, very, very high occurrence with this one, okay? And obviously NMS for anything that blocks too much dopamine, because that's caused by little dopamine, right? It's also very, very cheap, very cheap. So what were the other side effects that were involved? Remember my mnemonic, AWOL times 4. Okay, because it's a antipsychotic, and that's, they try to run away when you try to give it to them. So anticholinergic effects, weight gain, orthostatic hypotension, and liver dysfunction. Then the 4 S's: sedation, seizures, sexual dysfunctions, and skin effects. Okay. Then we have our second generation antipsychotics, which are our atypical ones. The class is serotonin/dopamine antagonist, so it blocks both. So that's why it's good for both positive and negative symptoms, and it's very important to understand the concepts, right? So like, what is my patient presenting that would allow me to, give them this? So for example, I have no energy and I'm seeing hallucinations, seeing shadows or whatever. That's a good indicator that I should give them a second generation antipsychotic, right? So what are the medications? Remember, this is ROCQ, ROCQ, risperidone, olanzapine, clozapine, and then the last one is quetiapine. Now, adverse effects singled out again, remember, low EPS, which is why we like it, low EPS. Still NMS, because why? It also blocks dopamine everywhere throughout the body, okay? And then the agranulocytosis with the specifically for clozapine. So what is the other side effects? Remember, this one is ass, right? Because they got away. So the first three were very the same from before. So we have orthostatic hypotension, anticholinergic effects, then we have sexual dysfunction, and the specific one was sleep disturbances. All right. The price for these are very expensive just because of, that they minimize the EPS occurrence. And then don't forget, we also talked about our anticholinergics as well. Just a brief review, benztropine and diphenhydramine. Remember, those help with the EPS. And generally, we can actually give them together. The doctor may do that just to try to minimize the EPS occurrence, okay? So now focus. We did a focus on the extreme complications, adverse effects. So everything is very similar to the ones that we talked about before that I singled out. EPS, NMS, and agranulocytosis. I added one more. It was anticholinergic symptoms/toxicity. And the reason why is because all of them cause anticholinergic effects. Even our anticholinergics, obviously, benztropine, diphenhydramine. So it's very important to know that as well. And this is also in our PowerPoint, so I included it there. It was a little bit mishmash to talk, elsewhere. So that's why I included it in our extreme complications, okay? Because it can happen to any of them. So starting with EPS, remember we talked about our 4 that are associated with EPS: acute dystonia, pseudoparkinsonism, akathisia, and tardive dyskinesia. Remember, acute dystonia, sustained muscle contraction or spasms, producing abnormal postures like BAM! And they're staying like that. Could you imagine? Yeah, tomatoes done thrown at them because they just dabbing all day long. Mostly seen in the neck up, but can happen anywhere. Pseudoparkinsonism, remembering Parkinson's signs and symptoms, which is a little bit of exception. So the ones that we're familiar with is shuffling gait, the slow movements, tremors. The exceptions that we haven't learned was the hunch posture and the pill rolling. That's a very big one too. Then we have akathisia, constant state of unrestfulness, distress, agitation. And they're just walking around. They're always fidgeting, wiggling their toes. They just cannot sit still. Then we talk about NMS. Remember, NMS is a neuroleptic malignant syndrome caused by too little dopamine. Okay, so this is because we are taking these dopamine antagonists, right? They're blocking it. So it blocks throughout the entire body, even though we only want it right here. So specifically, what are our signs and symptoms here? It is hyperpyrexia, okay? Muscle rigidity, BP fluctuations, tachy, so tachycardia, tachypnea. Then we have decreased level of consciousness or drooling, right? And then our nursing interventions for that is, if they have the muscle spasms, we definitely want to administer dantrolene, right? Just like before. High temperature, acetaminophen. Blood pressure, do we do anything about that? Especially with beta blockers? No. Because what if it slumps, right? We do not want them to drop even more. Then we have talked about agranulocytosis. So that's the self-destruction of white blood cells. Cause? Clozapine. So what are we doing? Nursing interventions, we have to educate them. You need to come back frequently or monthly for your white blood cell check, your blood draws, because we don't want them to get an infection or get some type of illness, okay? And then the one that I wanted to talk about was anticholinergic symptoms plus toxicity. Remember, this is caused by taking the anticholinergics, right? They all cause anticholinergic effects. So what do we expect to find? Dry mucous membranes, reduced or absent peristalsis, non-reactive pupils, urinary retention, tachycardia, and those are the less severe ones. But then we have delirium, seizures, repetitive motor movements, and those are the big ones. And so that's that for that topic. Let's move on to our next chapter, communication and aggression, anger, violence. So starting with communication, what is the purpose of therapeutic communication? We talk about therapeutic communication all the time, okay? And this is no different, because definitely when we're interviewing someone who may have potential for schizophrenia, we definitely need to employ very therapeutic communication, so we don't want to offset them in any way. And also it's good to obtain any information that we may need from them as well, as far as onset goes or their experiences. So it's very important for that. So, back channeling off of that, what is the purpose? Establishing rapport between the nurse-patient relationship, demonstrate that you're caring for them, being able to obtain crucial information about thoughts and feelings, and then hopefully using that to facilitate behavioral changes. So I think it's a little bit easier to kind of organize things for you. This is directly from the ATI book. This is also part of our key points that was provided to us in class. So I just thought, maybe take it from the ATI book and kind of go over it. It's on the second page of the key points, saying all therapeutic and non-therapeutic communication techniques. So here they are. Let's talk about them. What are the rules to communication? Okay. Always focus on how the client is feeling in the now. Never ask why. Okay. We already know that. And then the third one, obviously, all the non-therapeutic techniques that we have learned prior. We definitely don't want to offer advice for stuff either. Okay. So just put that as just a reminder to make sure you remember your non-therapeutic techniques. Now, silence. Let's start with let's review the categories. We have silence, active listening, clarifying techniques, questioning, centering, empathy. Okay? So that's all our, what we would use in an interview or how we would talk to them. So silence allows for meaningful reflections. Active listening is essentially employing solar, right? That's part of the nonverbal active listening. But the importance of this is to be able to hear and observe and understand what the client has to say and then provide effective feedback. Okay, that's active listening. So clarifying techniques. Here we have restating, reflecting, paraphrasing, and exploring. Okay, so restating is using the client's exact words. Reflecting is directing the focus away from, you and back to them, okay? So that they can further examine their feelings. And it's just kind of an in-the-moment thing. I don't know if I have a specific example, but you understand. It's just basically redirecting it back. Tell me more about this. Tell me more of that. So that they are the ones that are more involved with exploring themselves. And then reflecting. Paraphrasing is restating the client's thoughts for the client to confirm what has been communicated. So for example, if they are saying, I think I'm ugly, I think I can't do anything in life, right? So paraphrasing would be like, oh, it seems to me that you seem concerned about your appearance, right? Tell me more. That's paraphrasing. You see how that goes? That's different than restating, because restating is like, you think you're ugly? Which obviously there's better ways of, the better examples, but you're using the client's exact word. That's restating versus paraphrasing. And then exploring is basically probing to allow the nurse to gather more information. That's pretty easy. Questioning. Questioning, we can open-ended question or close-ended question, right? So open-ended is, we already know. facilitates spontaneous discussion and interaction, whereas closed-ended is for a gathering of specific data. So the first one, open-ended, tell me, versus closed-ended would be like, do you? So it's like that. But do not use too much closed-ended, only specific circumstances where you're trying to gather specific information, but that can block further communication. Projective versus presupposition. So projective, you're using like a hypothetical what if solutions. So uses what if to explore feelings to gain greater understanding of problems and possible solutions. So what if your couch was on fire, right? We learned about that for week 1 in my video, so to test insight. That's the same thing. What if? Projective. Presupposition is similar but different. Presupposition explores clients' life goals and motivations by presenting a hypothetical situation where they don't have the mental disorder anymore. You see how that's different? The other one is what if, like, and they still have the mental disorder. But this is like, oh, what if you no longer had this? What would your goal be? Presupposition. Centering techniques, we have focusing, asking questions or directing it towards a specific point. What's important. It helps focus on what's important. Giving information. It helps provide information or details that the client can use for decision making. Presenting reality helps the client focus on what's actually going on right now to dispel delusions, hallucinations, or faulty beliefs. And that's what we talked about prior, very briefly, displacing belief after acknowledging, it seems like you're really scared or you're frustrated or whatever that there are clowns here. However, it seems highly unlikely that there would be clowns because we're in a hospital, that's presenting reality. And then summarizing, providing important detailed bullet points of what was learned and, what was educated. Empathy, offering self. Offering self is a big one. It shows willingness to spend time and indicates genuineness. So an example of this, of offering self, is I'd like to sit with you for a while to help you get comfortable. Or, they're sad or whatever. It's like, can I sit with you? That's offering self. It shows genuineness. Next is touch. The thing with this that you always have to remember with touch as well as eye contact, okay? Touch and eye contact kind of go similar hand in hand. Culture is a big role, okay? Some Asian cultures and some, foreign cultures, they don't like eye contact and they don't like touch. So do not be rash and just go and hold their hand or put their hands on them, okay? So be very careful of that, but touch is an empathetic gesture, okay? And lastly, showing acceptance and recognition, because that ultimately demonstrates a non-judgmental attitude and helps shows interest, So the last couple notes that I have for therapeutic communication and our communication techniques in this first topic out of just 2, the next one is just anger, aggression, and violence, is that you want to help them encourage looking at the pros and cons of side of things, focusing on the facts and the client's perceptions to clarify their problems. You also want to look at nonverbal behaviors, okay? So say during the interview, they keep looking at something or they keep eyeballing something, you want to address that, sometimes something's wrong and you can get to the bottom of it. And an example that we'll talk about in a practice question, I believe one of the patients is keep looking at the door. You just bring up, it looks that you keep looking at the door, tell me what's the matter. So that's looking at nonverbal behaviors, making sure that you are being keen of that. And then again, displacing belief after acknowledging it, okay? You don't want to just be like, okay, and just leave, and then they're just having their delusions or whatever, okay? You also don't want to be rude, like, that can't be possible. There's no clowns in the hospital. You want to acknowledge their feelings and then try to, take them out of that mindset. And that concludes therapeutic techniques and communication. Within our topic of communication and anger, violence, and aggression chapter, now we get to anger, aggression, and violence, the second topic. So what is anger? We're going to talk about what is the difference between anger and aggression / violence. Our nursing cares that would be involved. such as, maintenance of milieu and also therapeutic communication. And then our types of restraints when they're having violence or aggression. So very simple end of the topic chapter. So starting with what is aggression. So aggression is the emotional response to frustration or desires, right? So maybe they're not getting something that they need, so they're getting angry, right? And sometimes they may feel this way because, like I said, desire, so threat to one's needs, or maybe they're being challenged, right? And that's why they feel angry. So what's the difference between that and aggression and violence? Well, aggression/violence is action or behavior that is sought out to harm a person or an object. And so here we talked about the most common areas where aggression and violence may occur. So psychiatry, emergency, and geriatric units, right? What are some risk factors involved? Well, clients that have a psychotic disorder, obviously, maybe an individual may have poor coping skills, and that's why. And then, most importantly, violent living environment. Okay, violent living environment. So, in the now, currently, predictors of violence. The number one predictor is limit setting by the nurse. So, you limit set them, and then you find that they are having some sort of aggression or whatever because you're taking some of their liberties away, right? That is the number one predictor. And how would you know? Okay, how would you know when it escalates? So these are the things that you look out for: anger, anxiety, and tension. Okay, increasing anger, anxiety, and tension. I'm sorry. So how would you see this? They're starting to get more argumentative with you, or maybe they're using curse words, right? Conversely, they could be, they could just flip the switch and just shut down. They won't talk to you anymore. Stone silence is what they call it. And this is abnormal because sometimes if they've never exhibited this behavior of being isolative, then that's when we know it could be a predictor of violence or aggression or anger. And then the other two, which is a little bit obvious, but obviously if they're intoxicated or they have alcohol or they have drugs in them, and if they have a weapon, obviously, come on. So those are the predictors of violence. Then we talk about nursing care. So again, very easy, our therapeutic actions. So what happens, but this is specifically pertaining to aggression and anger and violence. So specifically, what should we do to help try to de-escalate the situation, okay? Or try to stop it from going there? Well, we definitely want to give personal space, okay? If we know that someone doesn't like being, in their bubble, they want to be themselves, but generally, we want to also give personal space anyways, okay? Sometimes we also want to, if we want to de-escalate a situation, we don't want to appear intimidating, like hovering over them, right? So for example, if they're on the ground and they're scared, and then you, this big old person standing over them, shaking your finger, no, you want to get on their level, get on their eye level, okay? So if they're on the floor, you better get on your knees and get on the floor too, so that you don't freak them out, right? You know why I did that face. Get on your knee. Anyways, avoid accusing and threatening, right? Of course. This can increase defensiveness. And then also, lastly, offering choices to help de-escalate them. Okay, so maybe physical activities is a good one. Going outside or taking them out of that environment or situation, which leads to the next part of therapeutic therapy, I guess, is maintenance of milieu. So making sure the environment is safe, clearing it out, removing anything from that place that could be dangerous, especially when they're in that state, right? You want to maintain that milieu. And then lastly, medication or restraints as needed, which leads us to our last topic, the 4 types of restraints. So restriction of a client's movements, okay? This is very simple. It's funny because it doesn't seem like you're restricting their movement, like you're not holding them, that's physical. Restricting a client movement is essentially blocking their way of exit. So having staff just stand there, that's actually the first type of restraint, okay? The other one is physical Physical is like physical, hands, right? You're actively trying to hold down a patient. Now, the thing with physical is that you can use physical if they are actively combative, like they're doing battery, like they're punching someone, like a nurse. That's when we can hold them down without an order, okay? Because they're a danger to others. Chemical is the next one. Obviously, this is just restraints, okay? But obviously, we know our pyramid was therapeutic communication, non-therapeutic communication. We have our milieu, and then we have our chemical, seclusion, and then our mechanical, right? But this is just specifically talking about restraints in general, okay? So we talk about restriction of clients' movement, standing in the doorway. We have physical, holding them down, especially when they're combative. That's when it's justifiable. They can't file a tort if they're doing battery, okay? That was part of our practice questions from our Kahoot. Then chemical obviously requires an order, schedule, PRN, or emergency intervention. And then lastly, after we exhaust everything, okay? After we exhaust that pyramid, after we exhaust this too, would be the mechanical restraints, wrists or ankles. View communication, aggression, anger, and violence. So remember, therapeutic communication, what's the purpose? Establishing rapport, right? Demonstrating that you're caring and also being able to obtain crucial information and feelings so that we can make appropriate behavioral changes. What are our rules for communication techniques? Number one, always focus on the now, how the client is feeling right now, okay? Never ask why. And then obviously understanding our non-therapeutic techniques as we talked about, in fundamentals, never offering advice and never challenging, never being judgmental, etc. So let's talk about communication techniques. We talked about silence, allowing for meaningful reflection. We talk about active listening, right? So active listening, we can use solar. Never forget solar. That's our non-therapeutic way. That's our non-verbal therapeutic way of demonstrating active listening. And clarifying techniques, we talked about restating, reflecting, paraphrasing, and exploring. So restating, exact words, right? Reflecting, directing focus back. Paraphrasing, restating the client's thoughts to confirm what has been communicated. Exploring is just allowing the nurse to gather more information. You're probing them. Questioning, we talk about open-ended versus closed-ended and projective versus presupposition. So open-ended is obviously great for spontaneous responses and interactive discussions versus closed is only good for specific answers. Projective is a what if to explore feelings and gain greater understandings of how they would solve certain problems. And presupposition is when they are hypothetical, like what would you do, what are your goals be if you didn't have this mental disorder, if you no longer have this. We talked about centering. Within centering, we talked about focusing, giving information, presenting reality, and summarizing, right? So focusing, concentrate on what's important, okay? Your questions go along to what is important. Giving information to help provide details so that the patient can make decisions. Presenting reality, remember, that's to help focus the client on what's happening right now, to dispel illusions or hallucinations. And then summarizing, emphasizing the important points and to review. We talked about empathy. Empathy consists of offering self, touch, and showing acceptance and recognition. So offering self is like sitting there with the patient. That's offering self, right? Sitting there in silence with them if they're going through a hard time. Touch, remember, this is to provide comfort and care, but make sure you evaluate cultural considerations with this. Lastly, showing acceptance and recognition is to provide for a non-judgmental attitude and help show interest. Now, important notes to consider in your client interview is to help them probe the pros and cons of, their perception, their facts, to help clarify the problems, making sure that you're always looking at their non-verbal behaviors so that you can potentially de-escalate or address some certain situation that may be present. And then lastly, dispelling belief after acknowledging them, okay? So, I don't see a bird over your head, but I can understand how that can be upsetting to you. However, it's unlikely because we're in a hospital and they don't have birds in the hospital. So that's how you would do that. As far as anger, aggression, and violence, what is anger? Well, anger is the emotional response to frustration of desires or needs, right? So maybe they feel threatened of their needs, or maybe they're being challenged, right? But aggression and violence is action or behavior that aims to harm a person or an object. And what are the three settings that they are normally highly exposed to aggression and violence? The emergency, the psychiatric department, and geriatric units. So what are some risk factors involved to develop anger? Clients who have psychotic disorders, poor coping skills, or have been in a violent living environment. Remember the predictors of violence: increasing anger, tension, anxiety. Alternatively, monitoring their normal behaviors, and all of a sudden now they're stone silent, they don't want to talk to you. Alcohol and drug intoxication can obviously influence some anger as well, possession of a weapon. Then lastly, we talked about nursing care. So therapeutic actions, you want to give space, personal space. If they're having aggression, you see that they're having aggression, and what if they're having paranoia or they're getting a panic attack or whatever, you want to keep at a distance, obviously, personal space, keeping eye contact at their level because you don't want to freak them out. Do not accuse or threaten them, and offer choices to de-escalate. Like how about we go outside and talk, or this or that. Physical activities is a good one. You want to maintain the milieu if they're having aggression too, because safety. Remember, milieu is all about safety and success. So we want to remove objects that they may use as weapons or that can be thrown to make it safe so they can de-escalate. And then if needed, we can do mechanical restraints or medication, which leads us to our types of restraints. Restriction of a client's movement, so blocking a doorway with a staff member even. Physical, actively holding someone down, especially if they're attempting to leave or cause harm. They're doing battery on somebody. Chemical, scheduled PRN or emergency medication, and we have mechanical restraints as well. And that's that. So let's just, do some questions for this one. An adult with paranoia becomes agitated and threatens to assault a staff person. What is the best initial intervention? A, tell the patient, if you do not calm down, seclusion will be needed. B, address the patient with simple directions and calming voice. C, help the patient focus by rubbing the patient's shoulders. D, offer the patient a dose of antipsychotic medication. E, reorient the patient to time and place. You definitely want to do the most non-invasive and the most therapeutic. So it would be addressing the patient with simple directions and a calming voice. The last practice question is, which patient behavior is a criterion for mechanical restraints? Screaming profanities, assaulting a staff member, okay, obviously, but refusing a medication dose, and hovering near exit doors. So assaulting a staff member, not hovering near exit doors because they're not attempting to really leave, and you can't really assume that they're gonna try to sprint and take off. So that is that. Now it's time to do our practice problems, but before I begin, I just wanted to throw in one last thing, very random, but it will help with your ATI practice problems. So the difference between paranoid schizophrenia and disorganized schizophrenia, these two we didn't talk about in class, but it was kind of just an expectation to understand what they were based on the root words, but I just wanted to make sure that we get it, okay? So paranoid schizophrenia is unreasonable suspicion, primarily positive symptoms, right? And so they just delusions. They're thinking delusions versus disorganized schizophrenia is disorganized. So disorganized speech, that's why the word salad, right? Disorganized behavior, so difficulty finishing starting class, a task, difficulty acting appropriately in social situations. That's what disorganized is. Super random, I know, but I just want to make sure that everyone is kind of on the same page and no random term is going to throw you off, okay? So let's start finally with our practice problems that we received. So obviously we have the answers, but it's just nice to sometimes get a rationale based on everything that we've been learning about to kind of neatly wrap up everything. So a patient asked, what are neurotransmitters? The doctor said minor imbalance. Select the nurse's response that provides the most accurate information. So, what medication are you taking? Are you experiencing side effects? Do they protect us from harmful effects of free radicals? No. Neurotransmitters are substances we consume that influence memory and mood? No. Protect us from harmful effects of free radicals? No. D. Neurotransmitters are natural chemicals that pass messages between brain cells. We know this. The nurse administers a medication that potentiates the action of GABA. What effect would be expected? Reduced anxiety, improved memory, more organized thinking, or fewer sensory perceptual alterations. Remember our neurotransmitter imbalances, right? So if we have low GABA, we have anxiety. So this drug is to help with that. So that's why we'd have reduced anxiety. Exclusive use of Western physiological theories by nurses making client assessments will result in, well, will it result in high level of care for all clients if we're using Western physiological theories? Absolutely not. Because you know why? We need to make culturally appropriate assessments, right? Because some things do not apply to others. So will exclusive use of Western physiological therapies provide a standardization? No, because remember, when we are making client assessments, we have to adapt to each client that comes, which is why exclusively using Western physiological theories may be an inadequate assessment of the diverse cultures of a client. So I know this is taking it back to physical assessment, but remember, we have like cupping and coining and pinching. Well, we may interpret that as abuse, right? We're like, oh my gosh, abuse, or what happened to you, right? But that's normal for them to have the cupping itself. So that's why we need to take that into account. In which part of the nursing care plan should we expect to find this statement? Offer snacks and finger foods frequently. Again, part of ADPI. So this is part of our intervention because we're doing it. Okay, we're not evaluating it because that would mean like, oh, was this good? Was this bad? How can we adjust? We're not diagnosing it. This is a plan. Like this, not a plan. This is an action, right? So we're intervening. A nurse assesses a newly admitted client diagnosed with Alzheimer's and a urinary tract infection. The nurse asks the client's sibling for information about the home environment, ADLs, and medications. What type of source is the sibling? Okay. This one is taking it all the way back to professional nursing. Primary source, the best source of information is from the patient. That's primary source, okay? So secondary is someone that's related, that's closely related to the patient. So obviously like a sibling or like the family member. So secondary is that answer. All right. A nurse taught a client about important precautions associated with the new prescription. Afterwards, the client accurately summarized major self-management strategies associated with this drug. Which step of the nursing process applies to this client's summarization? Obviously, summarizing the associated management strategies that were learned is obviously evaluation, okay? Because intervention is like teaching them, right? Diagnosis is like, oh, knowledge deficit. Okay, 7. Which of the following would be assessed as a negative symptom of schizophrenia? So negative, all the A's, so meaning absence of, right? So anhedonia, hostility, agitation, or hallucination. So anhedonia. Funny because I said all the A's and then we have agitation, but you understand what I mean. Anhedonia is lack of pleasure, so the loss of it. So which symptom would not be assessed as a positive symptom of schizophrenia? Okay, would not be assessed. So let's read this. Delusions of persecution, auditory hallucination, affective flattening, idea of reference. So which is not a positive symptom is basically what they're asking. Affective flattening, because affective symptoms are the ones that have to do with emotions, right? So flattening of it, that's a negative symptom. And we'll just talk about this. Remember, delusion of persecution, things are going after you. Auditory hallucinations, obviously. Idea of reference is attaching personal meaning to something, right? That's like for example, like the TV, and they're thinking that they're talking about them. So, which side effect of antipsychotic medication is generally non-reversible? So, anticholinergic effects, pseudoparkinsonism, dystonic reaction, or tardive dyskinesia. I emphasize this a lot. Tardive dyskinesia is the one that you cannot reverse. It's lifelong, forever. A client diagnosed with disorganized schizophrenia would have the greatest difficulty with the nurse. So, disorganized schizophrenia, okay? Would they have greatest difficulty interacting with a neutral attitude, giving concrete language, giving multi-step directions, or providing nutritional supplements? I know this was confusing, but multi-step directions because it's disorganized. They cannot process, right? 11. Process linearly. Think linearly is what I meant. Okay. When a client is diagnosed with paranoid schizophrenia, he tells the nurse, I have to get away. The Volmers are coming to execute me. What is the appropriate response of the nurse? A. You are safe here. Please lie down and try to rest. B. I do not believe I understand the word Volmers. Tell me more about them. C. Why do you think someone or something is going to harm you? D. It must be frightening to think something is going to harm you. So this one goes back to what I said, trying to employ therapeutic communication, right? So you are safe here, please lie down. You are challenging them, okay? Never do that, all right? I know you're trying to dispel their beliefs, but that is definitely not the first thing you should do, right? You don't just straight up go, that's not true. I do not believe I understand the word Volmers. Please tell me more about them. So this one, I believe I would have fallen for, so do not fall for. I know it is trying to explore it, but the problem is Volmers is not even a word, right? And that is not your priority setting to begin with. But also, you don't want to make them be more paranoid. So when you dive more into the delusions, it can make them more upset, right? Why do you think someone's going to harm you? Why? You never want to use why. So you want to sympathize. It must be frightening to think something is going to harm you. That is like therapeutic communication 101 ATI style, and we know that, okay? Which assessment finding is the best predictor of violence in a newly admitted client, right? So this one's kind of hard. A recent assault on a drinking companion. B, a family history of bipolar disorder. C, the nurse's subjective feeling that the client is uncooperative. Or D, a client history of being bullied at school. So D, I picked D the first time I did this test, okay? But I thought about it, and I've asked a couple people. Childhood history, okay? Is that the best predictor? Okay, I got bullied, and you don't see me whapping and thwapping someone. Oh shoot, I'm neologism. I'm making my own words, but you get what I mean. Okay, recent assault. Okay, this just happened. This is the now. All right. So I know that was a little bit of a tricky one, but this one is more relevant, I guess I could say, to them being newly admitted. See. Number 13, which would be the most appropriate response by the nurse to help a client who is demonstrating escalating anger? So, A, walk the client to his room and help him practice stress reduction techniques such as deep breathing or muscle relaxation. B, suggest that the client spend some time in the gym with a punching bag. Suggest that the client spend time pacing rapidly in the hallway until his stress is relieved. D, sit with the client in the day room so that he can vent his anger and not isolate himself. Wow. Okay, so the answer is A, walk the client to his room and help him practice stress reduction techniques like deep breathing and muscle relaxation. This is obviously the most, therapeutic one. You don't want to go, blah, 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 blah. That's just gonna increase anger. Pacing rapidly? No, of course not, right? And sit with the client in the day room so that he can vent his anger and not isolate himself. Though that's good, that's just not addressing the issue, you know? You want to make sure that you're helping them de-escalate, okay? 14. A patient diagnosed with schizophrenia tells the nurse, the CIA is monitoring us through the fluorescent lights in this room. Be careful what you say. Which response would be the most therapeutic, okay? So A, let's talk about something other than the CIA. B, it sounds like you're concerned about your privacy. C, the CIA is prohibited from operating in healthcare facilities. D, you have lost touch with reality, which is your symptom of illness. So the most therapeutic is obviously B. It sounds like you're concerned about your privacy. We know this. This is paraphrasing. Remember, part of our therapeutic communication techniques. 15. A nurse interacts with a newly hospitalized patient. Select the nurse's comment that applies the communication technique of offering self. So, I've also had traumatic life experiences. Maybe it would help if I told you about them. Okay, right off the bat, no. You're slipping into a social relationship if you do that, by the way, okay? You don't want to always talk about your own experiences, okay? You want to help them by them telling you so you can navigate them and practice positive coping mechanisms, right? B, why do you think... Okay, first off, why? Never use why. That's already out. C, I hope you will feel better after getting accustomed to how... No, because you're not helping them at all. You're just like, I hope you feel better. D, I'd like to sit with you for a while to help you get comfortable talking to me. Obviously, that's offering self. That is the definition of offering self, actually. And that is the example that I provided to you guys already. A patient tells the nurse, I don't think I'll ever get out of here. Select the nurse's most therapeutic response. Don't talk that way. Of course you will leave here. B, keep up the good work. You certainly will. C, you don't think you're making progress? D, everyone feels that way sometimes. And it's actually C. I know I said it kind of sassy. You don't think you're making progress? But that is a form of, again, paraphrasing as well. And helping them reflect, right? Obviously, you don't want to do the first one. Don't talk to me that way. What the heck? Keep up the good work, and you certainly will. You're not addressing their concern, okay? So C, you don't think that you're making progress? That opens up the communication so that you can exactly identify, okay, why do they feel that way? 17. During the first interview with a parent whose child died in a car accident, the nurse feels empathetic and reaches out to take the patient's hand. Select the correct analysis of the nurse's behavior. A, it shows empathy and compassion. It will encourage the patient to continue to express his feelings. B, the gesture is premature. The patient's cultural individual interpretation of touch is unknown. C, the patient will perceive the gesture as intrusive and overstepping boundaries. D, the action is inappropriate. Psychiatric patients should not be touched. This one, oof. We learned that touch is part of empathy, right? But I also said touch is an exception. You have to be very, very careful of cultural considerations, okay? So it's B, the gesture is premature. You don't know how they respond to touch, so you definitely don't want to invade their personal space, okay? 18. During a one-on-one interaction with the nurse, a patient frequently looks nervously at the door. Select the best comment by the nurse regarding this nonverbal communication. Remember, during an interview, you definitely need to assess for nonverbal things that may be going on. So A, I notice you keep looking towards the door. B, this is our time together. No one is going to interrupt us. C, it looks like you're eager to end discussion today. D, if you are uncomfortable in this room, we can move someplace else. So obviously it's A, right? Remember, you're addressing that nonverbal behavior to try to see what's going on. I notice you keep looking towards the door. 19. A school-age child tells the school nurse, other kids call me mean names and will not sit with me at lunch. Nobody likes me. Selects the nurse's most therapeutic response. A, just ignore them and they will leave you alone. B, you should make friends with other children. C, call them names if they do that to you. Me. D, tell me more about how you feel. Tell me more about how you feel. 20. A nurse is caring for an older client who begins to cry and states, I knew God would punish me, and I deserved this horrible sickness. Which of the following responses should the nurse make? A. Why do you think you deserve this punishment? B. Don't worry about being punished by God. C. Let's talk about what's upsetting you. Obviously, it's that. So I hope that helps. I just like going over it because sometimes I can tie in concepts from what we learned. But do not forget to go over your ATI book. Always read. Do the ATI questions at the end, okay? At the end of the things, because that helps wrap things up. I don't know if I talked about it, and if I did, I can't remember. But for the therapeutic communication one, that's in chapter 3, okay? All the effective communication skills and techniques is all right here. And remember to look at your ATI book for your medication specifics. I went off of the class similarities, okay? And all my mnemonics went off of that. So I hope that was helpful. Thank you so much for sticking around and, telling me that it was helpful or not during school. It really motivates me to do my best and also to give back as well. So good luck on quizzes, good luck on studying, and thank you so much.